artery on the back of the ankle, near the Achilles tendon, dorsalis pedis. And that's it. And then for pediatrics, femoral A-lines are placed, as well as radial A-lines. So for pediatrics, there's femoral A-lines as well as radial A-lines. And then pain control is also important. One of the things that are done prior or at the time of drawing the arterial blood is to give them a sucrose pacifier. So when the nerves are receiving pleasure, what afferent impulses are of pleasure, then the pain impulses are diminished. That's the thought behind giving the sucrose pacifier. It's like, okay, this is going to hurt. Let's saturate all of your nerve impulses with something good before we stick a needle in. One other thing that's different with drawing arterial blood from infants is when you have an A-line in and you've got some heparinized blood, if you take the heparinized blood out, throw it away, draw your arterial blood, they become volume depleted or blood depleted very easily. So you can't just throw away the blood that has the heparin in it. So it gets reinfused back into the infant. So that's one different from adults where we throw it away. Or no, we have the vamps now, or reservoirs now, where we don't have to throw away the blood. All right, this is showing you a normal capillary blood sample where the pH is 7.35. Normal CO2 from capillary blood is 45. And a normal P something O2, P capillary O2, is 40 to 49 torr. So when you remember blood gases, like the acidotic side of arterial blood is what you would get with capillary blood. So 7.35 to 7.45 is a normal range for the pH with arterial blood. So the acidotic side of that would be 7.35. The acidotic side for CO2, the range is 35 to 45, but the acidotic side is 45. So if you just remember, like acidotic side of an arterial blood gas would be a normal capillary sample. With oxygen level, that's about 10 torr less than their arterial blood. All right, so that's a normal capillary blood gas from 40 weeks gestation, but what about a neonate who's 25 weeks gestation? Would you still expect a normal capillary gas? And the answer is no. So you're accepting more acidosis and higher CO2s as being normal. So here it says in newborns keep the pH greater than 7.2 and you're okay. And the CO2s up to 60 and that's okay. And then with the chronic babies, they build up bicarbonate in their blood. So their pHs will be a little less acidotic and they'll have high CO2s. So those are the babies that end up with BPD after being on the ventilator for a while and their lungs get damaged and you get them off the ventilator, but still they have a low pH and a high CO2, just like a COPD blood gas with a high bicarbonate. When you're going to draw a capillary sample, you want to bring arterial blood flow to the area before you poke the finger. And you do that by, it says wrapping in a warm towel, but there's devices that produce heat. There's chemical heat, and you just break the sac where the chemicals are in it. That generates heat, and that's what you wrap around the the heel. It says to puncture the cutaneous layer of the skin and then correct the free-flowing blood into a capillary tube. All right, so let me show you a video.
I have a quick question. Is the capillary blood gas like taking place of the arterial blood gas? Is that what it kind of is?
Yes.
So neonates don't have ABGs, they get the capillary blood gas?
Yes. Yeah, with the capillary gas, you're not looking for exact oxygen level. You're looking more for the pH of the blood.
And to draw those blood gases for either way, you said for neonates is the temporal and dorsalis pedis.
Are possible sites other than the radial artery? Yes.
So the radial artery is the most common site in neonates?
Yes. Umbilical artery, to start a line, so I guess that would be the most common. And then the second most common is right radial. Arterial. Oh, here we go.
With the exception of PO2 measurements, specimens from arterialized capillary beds may be useful substitutes for arterial blood when assessing acid-base balance and the adequacy of ventilation on patients without readily accessible arterial sites. When drawing capillary blood gases on newborns and infants up to 12 months of age, the recommended skin puncture sites are the medial and lateral, inner and outer, plantar surfaces of either heel. To prevent bone penetration, punctures for the size of the heel must not exceed 2 millimeters. Punctures for the arch of the sole or the back of the heel must never be performed. For patients 1 year and older, the fleshy pads of the third and fourth fingers are the preferred sites. Because the thumb contains a pulse and its skin can be thick and callous, it is not a recommended site. Avoid the second or index finger, as it is typically more sensitive than the other fingers and may also be callous. Punctures to the fifth or pinky finger should not be considered due to the insufficient tissue depth and the potential for injury. Previously punctured sites, as well as sites that appear swollen, infected, or excessively bruised, should be avoided. Since the flesh on the pad is twice as thick as the flesh on the sides, puncture the pad at the fingertip rather than the sides. The puncture should be across the fingerprints rather than parallel to them to prevent blood from channeling away from the puncture site. Supplies include gauze, disinfectant, a skin puncture or incision device, warm compress or commercial peel warmer, heparinized capillary tube, a metal flea and magnet, a cap or other sealant, gloves, and a sharps container. Arterialize the capillary beds by pre-warming the site for 3 to 5 minutes using a warm compress or commercial warmer not to exceed 42 degrees Celsius.
The important thing to remember about drawing capillary blood gas is that we want to pre-warm the site so that we get a good flow of blood to the capillary beds. We want a good mixture of blood from the arterioles, the venols, capillaries, to render a test result that accurately reflects the patient's physiology. And when we do that, we minimize the potential for us to have to excessively squeeze the site, which can introduce contaminants in the form of tissue fluid and can also hemolyze the specimen. Therefore, we want to pre-warm the site to get a good blood flow and a good accurate test result.
Thoroughly cleanse the site with an appropriate disinfectant and allow to air dry. Do not blow on the site. Place the puncture device on the cleansed skin without compressing the tissue, and activate the device according to manufacturer's
We don't make that big of
instructions.
a puncture site anymore.
Dispose of the device according to OSHA guidelines and your facility's policy. Performing a second puncture or double sticking is against the standards and should not be attempted. Wipe away the first drop of blood using a clean gauze pad, since this drop contains tissue fluid from the trauma of the puncture and may dilute or contaminate the specimen. Allow the blood to flow horizontally into a heparinized capillary tube so that no air bubbles enter the device. Do not milk the site to facilitate blood flow. When an adequate sample has been obtained, apply pressure to the puncture site and seal one end of the tube with a cap or other sealant. Place a metal bar or flea into the open end of the tube and quickly seal it. Move the metal flea with the magnet to mix the specimen to prevent clotting. Transport the specimen at room temperature. When collection is complete, elevate the extremity and apply pressure to the puncture site using a clean gauze pad until bleeding has stopped. Never leave an inpatient or dismiss an outpatient until all specimens are labeled with the patient's name, identification number, date and time of collection, and the initials of the collector as specified in your facility's policy. CLSI cautions against bandaging the heels of infants since adhesives threaten the integrity of delicate neonatal skin. Bandages also pose a choking hazard to the infant. Inspect the collection area, especially infant cribs and car seats, for supplies and equipment that might also pose a choking hazard. AARC suggests transporting the specimen on ice if testing will be delayed beyond 15 minutes.
Okay.
All individuals who collect arterial blood specimens should be aware of the complications commonly associated with the procedure, as well as the measures to take in the event of their occurrence. Patients who experience complications or adverse reactions should be promptly assessed and treated according to your facility's policy. Be sure to document the incident following your institution's incident recording protocol. Due to the close proximity of nerves to both the radial and brachial
All right,
arteries,
this is not
arterial punctures may be painful to the patient. Should the patient experience an electric-like sensation, shooting pain, tingling, or numbness in the extremity, immediately remove the needle and apply firm pressure.
We know that already, right? All right, a little bit more notes and then we're going to stop. So as far as the accuracy of the capillary sample, if the baby's crying while you're getting the sample, it's possible that the oxygen level in the sample is going to be lower. That's why it's always good to look at the monitor, get your SpO2 reading before you even touch the baby. And then you'll have an O2 stat prior. So if you get the sample and the oxygen level is low, you'll be able to come to the conclusion it's because the baby was crying during sampling. If there's air in the sample, that's going to change the results, because remember how oxygen will equilibrate with room air. If you squeeze too much, you could be getting venous blood instead of capillary or arterialized blood. The Flea technique that they showed with the capillary tubes now, it's good enough just to have the coating of the heparin on the inside of the capillary tube. And the Flea, I think you only use it if you suspect that you got blood clots inside of your capillary tube. At what temperature should the blood gas capillary tubes be stored at prior to analysis? Yeah, so you can use room temperature as long as you're going to run it within 15 minutes. And then prior, if not, then you put it on ice. right, so that's it for capillary blood sampling. Now for apnea monitoring. Apnea monitoring is placing, it's typically for home use, where there's a monitor that monitors breathing in the infant. It's just a band that goes around the chest. Especially if they have a life-threatening event of not breathing or becoming bradycardic. You don't want to just send them home, and then if they're at high risk for SIDS, you want to be able to monitor that and catch it in case they do have a period of apnea. The way that the apnea monitors work is they measure chest movements and heart rate. The alarm is set to go off if the infant stops breathing for 20 seconds or if the heart rate slows to less than 80 beats per minute. Another name for an apnea monitor is impedance pneumography. Do you think you'd be able to recognize those words? Impedance would be as you're breathing and the chest touches the band around the chest. That's what registers as a breath. Pneumography would just be measuring air entry. But you don't really measure air entry with this. You're just measuring chest movement. That's the same thing. Have you noticed in the ICU, you get a respiratory rate reading on the cardiac monitors? Do you ever wonder how it's measuring respiratory rate?
No.
Yeah, it's measuring it just from movement of the electrode up and down, and that's what gets registered as a breath. So a patient could have a completely obstructed airway, and as long as the chest is moving up and down, it shows you a respiratory rate. It's not accurate like your ventilator. So if you're wondering, should I believe the monitor respiratory rate, or should I believe the ventilator? The ventilator is more accurate than the monitor. All right, so what are indications for apnea monitoring? Anybody at risk for SIDS, so it could run in the family. So if there's one baby that died from SIDS and the next baby ends up having an apnea monitor at home. Or if there's a life-threatening episode such as apnea, cyanosis, choking, or lifelessness that requires stimulation or CPR, those babies will go home on an apnea monitor. And it stays on them for 2 months. So they need to be free of any events for 2 months before the monitor can be discontinued. All right, so that's it about apnea monitors. And do we have much left?
We have 2
pages?
pages.
So transcutaneous monitors are electrodes that are placed on the skin, and they can tell how much oxygen is in arterial blood, how much carbon dioxide is in arterial blood, just from sitting on the skin. And the way that it works is that there's little warmers in the electrodes, and it warms up the skin. And when you warm up skin, you bring arterial blood flow close to the surface of the skin. And then oxygen, carbon dioxide will diffuse through the skin, and it can be detected at the surface of the skin. Carbon dioxide, very easily. So you could have a transcutaneous monitor measuring carbon dioxide and get a number, and then draw arterial blood, and they'll be very similar to each other. Oxygen, not so much. There's about a 10-to-1 difference between what the transcutaneous oxygen level is and when you're actually drawing arterial blood. All right, so it says electrode is placed on the chest or abdomen of the neonate. It reflects arterial oxygenation and arterial carbon dioxide. TCCO2, so transcutaneous carbon dioxide, perfuses tissue more readily than oxygen. Therefore, carbon dioxide readings usually correlate more precisely. The numbers are used for trending. And inside the transcutaneous monitor electrode, you've got the same thing you've got inside of a blood gas machine, where you've got a Clark electrode for the oxygen and the Severinghaus electrode for CO2. So it heats the skin to 43 to 44 degrees Celsius, and that could burn neonatal skin if it's on for several hours. So that's the reason that the site has to be changed every 4 hours. So typically what I'm seeing is the transcutaneous monitors are pretty much used for infants that are on high frequency ventilation, because you can't put an end-tidal CO2 monitor in the ventilator circuit. You don't have the normal breathing in, breathing out like you do with conventional ventilation. So how are you supposed to know what their CO2s are? Well, you could use transcutaneous electrode. But as far as oxygen level, well, you can just use a pulse oximeter. So you don't really need transcutaneous monitors when you've got a pulse ox. And then as far as CO2, yes, it can tell you if for some reason you stop ventilating and you're not catching it by observation or assessment. All right, so when you're calibrating the transcutaneous monitor, you can calibrate it to room air. So if you're holding the monitor in room air, what should the PO2 of room air be?
159
Yes, very good.
torr.
159 torr. So you expose it to room air, it should say 159. If not, then you calibrate it to 159. And then there's also a calibration gas inside the monitor for calibration. When you're placing a transcutaneous monitor, you avoid bony areas only because you don't have as good a perfusion when there's skin over bone, because any little pressure can prevent perfusion. Accuracy is affected by skin thickness and fat. So this can be used on adults. You would use it on the inside of the forearm because it's probably the thinnest skin for adults. If you have poor cardiac output and poor tissue perfusion, you don't get good readings. So just some pictures. It shows the skin. The monitor is sitting on the skin. Oxygen diffuses from the arteries through the skin tissue and can be picked up by the electrode. Here it is on an older child on the inside of the arm, only because the skin is thin enough at that point. With pulse oximetry, we know that it works by sending 2 wavelengths of light through the finger. One wavelength of light is absorbed by hemoglobin that has oxygen. The other wavelength of light is absorbed by hemoglobin with no oxygen. And from that, it sets up a percentage, and that's where you get your oxygen percentage. The second bullet says fetal hemoglobin wavelength absorption. It's the same as adult hemoglobin, so no need for a different monitor. With pulse oximetry, you want to make sure that your reading is accurate, because sometimes you'll get a low saturation reading, and the reason for the low reading is not because the baby is desaturating or even the adult is desaturating. It's just because your sensor isn't picking up properly. It could be cold extremities, so you don't have good perfusion going to the fingers or the hand. So one thing you can do is make sure that your waveform that picks up heart rate or displays heart rate agrees with the cardiac monitor. So that's one way to ensure that the values that you're getting are believable. Safe oxygen saturation. Are those the same numbers I gave you earlier? 85 to 92?
I thought it was the other one.
88 to 95.
Yeah, 88 to 95.
All right, so we need to correct that. You want to cross this off. and put down 88 to 95%.
Eighty-eight to 95 was infants greater than 34 weeks. So does that matter?
88 to 95?
Yes, you said greater than 34 weeks, and infants less than 34 weeks is 85 to 90.
Oh, all right, I gave you two sets of numbers. So 88 to 95, we'll stick with that for now. Raj?
For neonates, the pulse ox has to be placed on the right foot. Is that correct?
No. So to get preductal and postductal O2 saturation, it could be, it has to be on the right arm or right hand, and anywhere else in the lower extremities, so it could be the right foot or the left foot. It's not going to make a difference. Mhm. So we talked about co-oximeters and the pulmonary function lecture, where it measures specific hemoglobin and what the types of hemoglobin or what's attached to hemoglobin. And it gives you a more accurate hemoglobin saturation than just looking at O2 stats from a pulse ox or the iStat point of care testing, because it's actually directly measuring O2 saturation.
What is sulf hemoglobin? Is that when like sulfur is attached to it or something?
Yeah.
Oh, okay.
So this is just showing that your O2 saturation comes up a little bit different on the co-oximeter compared to the pulse oximeter at the bedside. And I guess the best thing to do is, bottom line, the pulse oximeter usually measures the O2 saturation about 2% higher than what actually is on the co-oximeter. So instead of looking at all these slides and trying to figure out what it says, pulse oximeter shows O2 saturation about 2% higher than co-oximeter O2 saturation. So if you have a pulse ox and you see an O2 saturation of 92%, and then you take some arterial blood and you go to the lab and you put the blood in a co-oximeter and you get an O2 saturation, what do you think it would be approximately? About 90%. So actual is about 2% lower. So when we're talking about keeping O2 stat 92 to 98%, why 92% and not 90? And that's the reason why. Your pulse ox saturation will say 92, but when you actually measure it in the machine, it's about 90% saturation. Okay, finished it. All right, so that ends neonatal lecture for today. We'll take a little break and then we'll talk about advanced equipment lecture.